Ma'am, with your permission, shall we start, ma'am?
Yeah, sure. Go ahead.
Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box given in the below, and we will have a short Q&A at the end of the webinar. And with this, I welcome Dr. P. Balamba, madam. Thank you for joining us, ma'am. It's an honor to introduce you, ma'am. Actually, madam doesn't need any introduction. She is known for her simplicity and very humble nature and down to earth nature. So, Dr. Balamba, ma'am, she did her medicine from Osmania Medical College, Hyderabad in 1968, and she completed her DGO from Kurnool Medical College, 1972, and she completed her MD in Obs and Gynecology in 1976 from the Osmania Medical College, and she is a former professor and HOD for the Department of Obs and Gynecology, Osmania Medical College, Hyderabad, and she is a former additional superintendent of Osmania General Hospital, Hyderabad, and former additional director for medical education, AP, and professor emeritus for Obs and Gynecology, NTR Health University, AP, and former president FPAI Hyderabad chapter. And at present, she is a consultant at Shalini Hospital, Barkatpura, and vice chairperson for AACOG 1998, and chairperson for organizing committee AICOG 2011, and former president OGSH 2008 to 9, and former secretary for OGSH 1996 to 2002, and she is a chairperson for governing body Prajwala Anti-Trafficking Agency NGO, and she is also president for Family Planning Association of India Hyderabad chapter, and chairperson for Project Advisory Committee Indian Institute of Health and Family Welfare AP, and guest faculty for AWARES Academy of Nursing Studies and Empowerment of Women, and she trained all the government and private medical college staff for prevention of parent to child transmission of HIV or AIDS, and she published various scientific papers in national and international journals, and she is a member of a medical advisory committee to Chief Minister Andhra Pradesh and medical advisory committee on surrogacy to government of Telangana. With this, we welcome you, ma'am, for today's webinar. Uh, yeah, over to you, your presentation, ma'am.
Thank you. Can I have the slides now, Sajita? Good evening, everybody. Let us talk about PCOS, that is for polycystic ovarian syndrome, and implications. Originally, we all know that this was known as a polycystic ovarian disease. And now we know it is not a disease, it's only a syndrome because it's a symptomatic presentation of various things along with polycystic ovaries. And the polycystic ovaries may be present, may not be present also. And that is why it has been called polycystic ovarian syndrome now. Though originally everyone thought it is the ovaries which are responsible for all the implications. And now we know the polycystic ovary presence itself is an effect of various problems in the woman rather than being a cause by itself. Can I have this second slide, please? Now, originally, it was described as steel and Leventhal, though even before that, it was described as a bearded woman in a bearded woman of having diabetes, much before that. And then, it became very prominent because they thought it is because of the ovaries that a woman is growing a beard and mustache and all those things. That is the hyperandrogenism. Now we, of course, know that hyperandrogenism, clinically or biochemically, is the principal culprit which makes the ovaries to become polycystic. So the understanding historically it is seen as a reproductive disorder characterized by amenorrhea, hirsutism, and polycystic ovarian morphology. And then clinical correlate became, when Steele and Leventhal did their first wedge resection, and the woman started having her periods regularly and then also conceived, then they thought, the culprit is only the ovaries and not something else, without knowing that they are reducing the androgens in the woman's body, and that is the ovulation has resumed in that woman. Now, 30 years ago, it was first reported that women with the PCOS had insulin resistance also, that is hyperinsulinemia. The current status is now PCOS was associated with a unique disorder of insulin action. And let me be very clear, insulin resistance is not present in all women who are having PCOS. But in obese PCOS women, almost 50 to 70% have insulin resistance, whereas in the lean PCOS women, it may be about 25 to 30%. The defects in insulin secretion and together these abnormalities conferred a substantially increased risk of glucose intolerance. That is how we came to know that type 2 diabetes can be a problem which can occur in these women with the polycystic ovarian syndrome. Can I have the next slide? Now, this is one of the most common endocrine disorders affecting women of reproductive age, seen in 8 to 11% of reproductive age group women, most common cause of anovulatory infertility in women, and 70 to 80% of women with PCOS will have oligo or anovulation. And Indians have among the highest prevalence rates in the world, that is 41% in the reproductive age. And this is not a surprise because India is the diabetic capital of the world, apart from China. So even here we have a very high incidence of PCOS. Maybe there is a correlation between PCOS and insulin resistance. I always used to think, when we look at the classification according to the National Institute of Health or the Rotterdam announcement or the Androgen Access and PCOS Society classification, insulin resistance doesn't come into that. But we all know that there is a problem of insulin resistance in PCOS cases, though it doesn't come into the classification. Next. Now, we all know that polycystic ovarian syndrome is a problem of genetic origin. It's a polygenic origin plus environmental influence. So, these two correlate. So, when there is an environmental influence, epigenetic factors will come into force and it will alter the DNA so that it gets programmed for these problems of polycystic ovaries. Now, fetal programming itself is a problem. We all know about the Barker's hypothesis, where the fetal programming for adult diseases has been elaborated by him from Scotland. And intrauterine growth retardation and small for gestational age babies are supposed to have a higher incidence of diabetes because for catching up, they will increase in their weight because the parents feel that the babies are born small, so they have to be overfed, and that becomes a big problem. And they will land up with insulin resistance, adipose tissue dysfunction, excessive postnatal catch-up weight gain, premature adrenarche, pubarche, menarche, and then as they become adolescents, they become obese, and then there will be visceral adiposity, that is the visceral fat will increase, and irregular menses will occur, especially in Indian women. Though we look very thin and not obese like the Western women, but the visceral fat is very high in us. And there can be anovulation or oligoovulation, acne, seborrhea, hyperandrogenism, hirsutism, all these will occur in adolescents. And as they reach the reproductive age group, there will be obesity, carbohydrate intolerance, dyslipidemia, and the most important presenting complaint will be infertility. And once they become pregnant, by whatever means, maybe the assisted reproduction or ovulation induction, or maybe ovarian drilling, there will be lots of complications in their pregnancy also, and they may end up with lots of premature deliveries and small for gestational age, preeclampsia, type 2 diabetes, and where we may have to induce labor also, iatrogenic preterm labor also can occur, and again the cycle repeats, because there's a small for gestation baby. So if a woman is having PCOS and we help her to become pregnant, she may produce another female child who also has PCOS. Now, when they reach menopause, This becomes a problem because they can develop type 2 diabetes, dyslipidemia, cardiovascular disease. The risk for cardiovascular disease may increase, though it becomes a little controversial. Further studies are required for this. And then, of course, hypertension, and most important, endometrial cancer, and maybe also breast cancer. So the main clinical and metabolic manifestation of polycystic ovary syndrome, according to women's stage of life, it differs from the infancy to menopause. So that is what we are going to discuss today. Next slide. So what is the spectrum of PCOS from childhood to post-menopause? The predisposing factors, like I said, is genetic factors in utero, programming, and in pre-pubertal years, it will be increased AMH levels. And amongst the children who are going to reach puberty, it can be premature adrenarche. Normally, we say premature pubarchy, that is the pubic hair and axillary hair develop first, and this happens much before the 8th year of age in these children, and that must make us suspicious of this child going for polycystic ovarian syndrome. And in a non-PCOS, during puberty, acne can be there. That doesn't mean that she is going to become a PCOS case at all. Hyperandrogenism is also there, and I will discuss about all these things when I come to the discussion of adolescence. And increased ovarian volume will be there in the non-PCOS children also, and increased GnRH pulse frequency is there in amongst both groups, and increased AMH levels, ovarian volume will be there, and there can be insulin resistance at puberty, which is important, and it has to be there for their growth spurt. And hyperinsulinemia persists in children who have PCOS, and irregular cycles will continue, whereas those children who are not going to have PCOS, the cycles will become regular in course of time once ovulation starts and once the hypothalamo pituitary ovarian axis matures. Now, as they are aging, there will be decreasing AMH, ovarian reserve, and antral follicle count along with age. Whereas in PCOS cases, the AMH will be high and they will have increased antral follicle count, and the cause of it also I'll be discussing later. And in the reproductive age group, there will be subfertility, infertility, increased AMH, antral follicle count, ovarian volume, which is very, very important, which we must insist the sonologist to report. And of course, they can have glucose intolerance because of insulin resistance. And postmenopausal years, there will be an increased prevalence of hypertension because of the free fatty acids and atherosclerosis, and increased triglycerides also because of the free fatty acids, and increased cardiometabolic risk factors with menopause in any other woman also, and adiposity and hypertension. So this is the phenotype of PCOS across the lifespan in comparison with controls. Next. Now, when we look at the predisposing factors in infancy, childhood, and puberty, and all those things, genes, environment is very, very important. And so much the epigenetic factors and the environmental factors have become important for us because obesity has increased. If you look at the National Family Health Survey 5 recently, the obesity in women and men both have increased, and it has increased more in men, of course, but also in women it has increased. And that may be because of the stress, one, and the eating habits have changed. We have left off the traditional eating habits and we have imbibed all the Western culture, and the junk food consumption has increased tremendously. And that may be one of the most important environmental change that is predisposing our girls and children to PCOS, because these children are undergoing a lot of stress, because right from childhood, even when they are in the primary school to middle school, they are put into all these techno schools, and the stress is so much. They have absolutely no time to play, and they have absolutely no time to eat proper meals at proper times, and that itself, makes them, because they're growing children, they're hungry. So whatever is available, they are going to eat, and that is why you see all these junk food shops coming along these techno schools. Wherever you go, you will find these junk foods around the school only, and that is what is making these children very, very obese, And because the parents are also maybe lack of time or maybe lack of interest, and they are not preparing home cooked food, they are not feeding their children properly, and that is the reason all these problems occur. Now, amongst the pre-pubertal and pubertal girls, acne, irregular menses, like I said, increased volume, they're all common. And again, in reproductive age, again, like I said, the androgen levels will decrease in the normal growing woman, which is who is not going to have PCOS, and the ovarian volume will decrease, and the follicle number also will decrease, whereas in PCOS it will not. And of course, menopause, naturally there will be, because the androgens will increase, even in a normal non-PCOS woman. The hirsutism will be more in the women who have had the PCOS, though by the time they reach perimenopause or menopause, their symptomatology will decrease, and even the polycystic ovary may become normal looking ovary, and they may be having regular menstruation also, because the number of eggs have decreased by now, and they may develop, of course, hypertension, triglyceride, which may also happen in non-PCOS women. Next. So this is the natural history: premature adrenarche, clinical hyperandrogenism, infertility and irregular menses. Then they go to diabetes mellitus, dyslipidemia, high blood pressure, obesity, and then land up with endometrial cancer and breast cancer. So when you look at the fetal life, this is the genetic and environmental factors. Maternal hyperandrogenism, like I said before, a PCOS woman who becomes pregnant and produces a female child, because of her hyperandrogenism, the fetal brain gets so tuned, that the LH will increase, and it is exposed to the hyperandrogenic genic environment. So the fetal brain also gets tuned to that, and they will have lower neonatal weight because of all the complications that this woman with PCOS is having. And then, in adolescence, they are going to have problems, and as also in the childbearing age, menopause and postmenopause. Next. So what about the classification? How are we going to diagnose? So in the 1990, the National Institute of Child Health and Development and the National Institute of Health together said patient will demonstrate both, that is a clinical and or biochemical hyperandrogenism. It is not necessary for us to test all these girls for testosterone or androstenedione or dehydroepiandrosterone sulfate. It's not necessary, because if this woman is having hirsutism, it may be mild, moderate, or severe. When I am coming to the Ferriman-Gallman score, I will tell you about that also. And there will be oligoovulation or chronic anovulation. So both have to be present, and they didn't include PCOS. And as a matter of fact, over a number of years, now we have come to a conclusion that PCOS morphology may not be there at all, even though the woman is having polycystic ovarian syndrome. Then in 2003, Eshrey and American Society of Reproductive Medicine in Rotterdam met, and then they said two of the three criteria should be there to diagnose PCOS: oligo or chronic anovulation, clinical and or biochemical hyperandrogenism, and polycystic ovarian morphology. So even if there is no hyperandrogenism, if there is a PCOS morphology and the woman is having oligo or chronic anovulation, you label them as PCOS. Then came in 2006 the Androgen Excess Society and PCOS group, which said they should demonstrate both hirsutism and hyperandrogenemia and oligoanovulation and or polycystic ovaries. So then, there was a lot of confusion. And then comes further, next. So in the adolescence, let us first discuss what is going to happen, and then we will go on to the different phenotypes of the polycystic ovarian syndrome as suggested by NIH, also as suggested by AES, that is Androgen Excess Society. Next. So the American Academy of Pediatrics in 2015, it defined adolescent PCOS as unexplained, persistent, hyperandrogenic anovulation. Now we have to be very, very careful when we are labeling a child who is coming to us, an adolescent, who goes with a maybe a period of amenorrhea, she missed her periods, And then she went for a scan. Somebody has suggested a scan, and the sonologist tells her, "You are having PCOS." The mother is terrified. And whenever these children come to us, gynecologists, what they will say is, "What is your problem?" You ask them, they will say, "I'm having PCOD." They don't know that the PCOD terminology is gone, and now it is only a PCOS and not PCOD, and that it doesn't mean anything in an adolescent, because ultimately she may not be a case of PCOS at all, but only an adolescent who is going through this phase of growing up. Next. So, what are the risk factors in these girls who are going to develop PCOS? They may have premature puberty, like I said, below 8 years. They may be obese. There may be a family history. Maybe the sister also has PCOS. The mother is having type 2 diabetes. And in the family history, you must ask the mother whether she conceived spontaneously, or she had to use assisted reproductive techniques or induction of ovulation, whether she also had such problems. Because, like I said, in the family history, this is very important, because fetal programming, if this woman has conceived this child, this particular child, then during her PCOS years, with induction of ovulation or with ART procedures, the child was conceived in a hyperandrogenic milieu, and naturally the child also is going to develop PCOS. Of course, ethnicity is very important. It is common in African American, in the Western countries, in America especially. But in our country, Indian children are also developing this, maybe because of the genetic problems, and maybe because the growth restriction is very, very common in our country. If you look at again the fifth National Family Health Survey, the stunting in children is very high in our country. And in fact, instead of becoming better over the years, in fact, we have become worse. And some of the states, even the better performing states, are, including our Telangana, is showing more incidence of chronic malnutrition, which results in stunted growth. And these are the children who may develop PCOS later on in life. Next. Now, it is very challenging to make a diagnosis. Now, why is it that in adolescents it's very challenging to make a diagnosis? Let us talk about this. See, the woman develops the pubarchy, then adrenarche or thaliarchy, whichever may come first. But if pubarchy comes first and the child is obese, and there is a history of small for gestational age baby or a fetal growth restriction in this particular index child, then if you just do a scan, it may show a stromal thickness, it may show a pattern of polycystic ovarian syndrome like this, but you cannot say that these children are going to have PCOS or already having PCOS, because there are three things that are happening during adolescence. Like I said, there is a growth spurt, and the organs are maturing now. The reproductive organs are maturing. And for this, the hypothalamo pituitary ovarian axis has to mature. And in the first 2 to 3 years after menarche, ovulation does not occur, and the LH surge is more than the FSH, because the gonadotropin stimulating hormone stimulates the LH more than the FSH. And insulin resistance is very, very common, and it has to occur. Insulin resistance has to occur because more and more insulin is required, because it's an anabolic hormone, and the children are growing at this present stage. And the somatotropin, that is a growth hormone, is also very important, because this is the time when the growth hormone is high and the child is growing up. And there are also adrenocorticotropic hormones, which may be influenced even by prolactin, which can stimulate the adrenal cortex to produce more androgens. And we all know androgens are anabolic. It makes the child go in for increased appetite, and wherein they require more calories because of the growth spurt at present. Now, as the hypothalamo pituitary ovarian axis is maturing, there is also there are two enzymes which are very, very important. The cytochromes. It is P450 C17 alpha, which is a bidirectional enzyme. It has a 17 hydroxylase and also 17 alpha lyase. It also has that, and both will be producing insulin resistance and hyperandrogenism. So So this is all required during puberty, and that is the reason we should not label these children as having PCOS, and we have to wait at least minimum for 3 years after the child reaches menarche before labeling them as a PCOS case. And I think this has to be actually explained to the sonologists so that they don't label these children as PCOS. And when they come to us, like I said, the child will say, I'm having PCOD. The mother is worried. The mother is only worried about her fertility. She thinks, this girl is not going to conceive children and it is going to be a big problem. So they associate PCOS only with infertility, and they are not worried about the other implications of PCOS at all, which we all have to educate them about. And lifestyle changes is mandatory because, like I said, environmental factors are going to cause epigenetic changes and going to worsen the genetic problem. It can be modified by lifestyle changes. So we'll have to sit and explain. So counseling becomes very, very important in these children and their parents first, and most importantly, the mother first. So it's challenging to make a diagnosis during the 1 to 2 years following menarche and ovulatory menstrual cycles. There is a transient multifollicular ovarian morphology because there is no ovulation, and there will be increased androgen effects by which I explained already, and there is a relative insulin resistance secondary to the increased growth hormone levels. So that causes all these problems. So you wait. Now AES, that is the Androgen Excess Society, says in a child who is an adolescent, please don't label them as a PCOS till they reach the age of 18, by which time you can say that there is a problem. And this problem, again, it is not only the number of follicles, antral follicles, which has to be more than 12, which should measure less than 2 to 9 millimeters. And the AES says it should be at least 25 and not more than 12. For adults, we say 12. But for these children, it should be more than 25 before we label them as a polycystic ovarian syndrome. Okay, next. So there is no validated diagnostic criteria to say that this child is having polycystic ovarian syndrome. But there can be an unexplained combination of abnormal uterine bleeding pattern. There may be periods of amenorrhea followed by prolonged bleeding, heavy bleeding, and abnormal for age or gynecologic age. Gynecologic age is from the time of menarche. Persistent symptoms for 1 to 2 years, and evidence of hyperandrogenism. There will be, because there is hyperandrogenism, these children, adolescents, once they attain menarche, may have a little hirsutism, which will not progress. But if they have PCOS, it is going to progress over a period of time. Now, persistent testosterone elevation above adult norms is a reliable reference laboratory, is the best evidence. Let me be very frank. Assessing the testosterone levels in the blood is a very dicey thing. Especially free testosterone is more important because that is what is going to act, and the 5-alpha reductase is going to act on this free testosterone and convert it into dihydrotestosterone, which is metabolically active. So we can't measure that, and most of the laboratories cannot give you a reliable level at all. So you depend more on the on the physical evidence of hyperandrogenism rather than the biochemical evidence of hyperandrogenism. And moderate to severe hirsutism is clinical evidence, like I said, and moderate to severe inflammatory acne vulgaris. That is, the acne which are not getting better on treatment. Normally, in the adolescent age group who are not going to develop PCOS, this can be treated easily. The dermatologist can treat it easily. But in the children who are going to develop PCOS, they keep on cropping up and they are not going to get better. And that is how you may think, please don't label them again, but you may think that these children are more likely to become PCOS, and these are the children who will require a very important counseling, very important advice about the lifestyle changes. So continued menstrual abnormality in a hyperandrogenic adolescent for 1 year prognosticates at least 50% risk of persistence. Therefore, early workup is advisable to make provisional diagnosis so that OC treatment which mask hyperandrogenism is not necessarily delayed. That is, so that the hirsutism does not become worse, so that you can start the treatment with the oral contraceptive pills which has a anti-androgenic progesterone in it. Next. So in adults, there is no controversy in defining PCOS in adults. Again, the NIH classification, the Rotterdam classification, and the Androgen Access Society classification. Now, of course, PCOS Society also has added on to AES. Now, next. Now, what are the phenotypes? These are the phenotypes, which can be there. And according to the AES Society, the phenotypes are from A to I. So there are so many phenotypes. Now, why should we know about these phenotypes? Because not all women who are having PCOS may have all the symptomatology of whatever being described by NIH or the Rotterdam criteria or by the AES Society. You will be surprised because some of the obese women, people themselves will come and ask you, I am obese, my neighbor is also obese, but when she got married, within 1 year, she conceived, she had absolutely no problem, delivered normally. And why is it that I am not delivering? This depends upon the obesity, the visceral obesity. That particular woman may not be having visceral obesity. She may be having a gynoid obesity in the woman, but whereas the woman with PCOS will have android obesity like a male. So the waist hip ratio will be more, the waist circumference will be more in these women, whereas in those women who are obese, so it is not only the weight, it is not only the BMI which matters when we talk about the phenotypes of the PCOS. So in a severe complete PCOS, the bleeding will be irregular, the ultrasound picture will be PCOS, androgen will be concentration will be very high, insulin concentration will be low, that means there is insulin resistance, and the frequency is very, very high, 61%. The fourth phenotype will be bleeding will be irregular, the morphology of the ovaries may be normal, androgen may be high, insulin resistance may be high, and it is only 7%. The next will be, bleeding will be regular, the ovulation will be there, and androgen will be high, insulin resistance will be high, and 16%. And these women may conceive on their own also. And then mild type of PCOS is, again, bleeding is irregular, morphology is PCOS, androgen may not be that much increased, there may not be much of a hirsutism, and insulin resistance may not be there, and they also may have 16% frequency. So these are the different phenotypes which we describe. Next. And when you come to the AES, like I said, A to I. See, so many combinations and permutations. This is what AES described in 2006. But still, even if there is no PCOS morphology, if there is hyperandrogenism, you label them as, provided you have excluded, of course, the late onset congenital adrenal hyperplasia and Cushing syndrome, or a ovarian tumor, which is a male hormone secreting tumor, then you'll have to label them as PCOS only. And these are the women who are going to develop metabolic disorders because of hyperandrogenism and hirsutism, because hyperandrogenemia perpetuates insulin resistance in these women. Next. So what is the appearance? Again, if you look at them, see, if a child has a hyperandrogenism, lot of acne, hirsutism, acanthosis nigricans. Acanthosis nigricans is the diagnosis for insulin resistance, a physical method of diagnosing insulin resistance. These are in the folds, in the neck, axillae, and the groin. There will be skin folds, and they will be yellowish brown, and they will usually go to a dermatologist first. And the dermatologist is the one who will say, you go to your gynecologist, maybe you are having PCOS, or they may even go to an endocrinologist. Now, insulin resistance, hyperinsulinemia, type 2 diabetes, naturally they'll go to a diabetologist or endocrinologist, or maybe if they come to us also, we will also refer them. Now, worsening follicles quality, unsuccessful ERT, they will go to a fertility specialist. Now, menstrual disorder, oligo or anovulation, and primary infertility or secondary infertility, they'll come to us. Now, in addition to all these, because of the body image, because the child is developing a lot of acne, obese, acanthosis nigricans is there, alopecia also may develop, especially the female type of baldness, where on the top of the skull they are losing hair. They will have psychological problems. They will go to depression because they are trying to lose weight, they are not able to lose weight. So these are all the problems, and they may land up because of the depression, because they are not doing well in the school and they are crying for, at the drop of a hat. The mother may feel, the parents may feel that there is a problem with the child, and the child may be taken to a psychiatrist also. Next. So, what is the challenge? In adolescence, there is a higher rate of physiological and anovulatory cycles, like I said, irregular menses during the first 2 years. Presence of acne is common in this group, very normal. Next. And they have functional ovarian cysts. The maximal ovarian volume will occur in adolescence, and we can't do a transvaginal sonography, so it is inaccurate. Transabdominal sonography is inaccurate, and clinical evidence of androgen excess will be there, especially acne, and common during puberty and resolves over time. High prevalence of obesity in adolescents. BMI more than 24 is associated with oligomenorrhea. Now we all know that the BMI, which is prescribed for the Indian women at least is 23. And rapid progression and exacerbation of hyperandrogenism occurs at menarche because of the growth spurt, like I said. Next. So the epigenetic risk factors. What are the epigenetic risk factors? Perinatal and infancy, congenital virilization, growth restriction, large for gestation age baby, rapid growth. In the childhood, again, premature puberty, atypical puberty, metabolic syndrome. They may attain menarche spontaneously, and then they have amenorrhea for one whole year. And you may think it is a case of primary amenorrhea. And believe me, polycystic ovarian syndrome, which is the phenotype 1, which is very severe polycystic ovarian syndrome, they may come to us with primary amenorrhea also, with everything. This is one of the eugonadotrophic primary amenorrheas, which the WHO classification describes. In adolescents, again, hyperandrogenism, anovulation, polycystic ovaries, they may even have metabolic syndrome. I have diagnosed type 2 diabetes even in children as young as 14 and 16 years also, and they usually are obese. Next. So what happens? Insulin resistance, android obesity, like I said, there is increased lipid storage because there is a visceral obesity, and in visceral obesity, free fatty acids are liberated very freely. They compete for insulin receptors, and they will decrease the sex hormone binding globulin, by which the testosterone get liberated. The free testosterone levels will be high, so hyperandrogenism occurs, and altered fat metabolism will occur because leptin, again, is another hormone which will convert androstenedione to estrogen also, apart from the aromatase. And hyperinsulinemia occurs to correct this insulin resistance. So what happens? Altered steroid hormone metabolism, because insulin also acts as a co-gonadotrophy. And the paradox is insulin resistance may exist in two places in a different way. There is an insulin pathway, one insulin pathway, two, like the insulin receptor substrate can be two types, type 1 and type 2. Type 1 may be working in one place and type 2 may be working in another organ. So this becomes very important for us to know also. So because of that, there can be a variable presentations also. And it also promotes LH binding to the receptors. And there is an increase of insulin-like growth factor 1 pathway, because insulin receptor resembles this, and insulin-like growth factor decreases, so that the androgen production from the theca cells will increase, and there will be acne and hirsutism and hyperandrogenism and infertility, and all this occurs because of the genetically programmed hypersecretion of androgen from the ovary. Next. Now, the prenatal origin, all the fetal origin is, which I explained already, where a hyperandrogenic mother conceives a female child. There is a hyperandrogenic milieu in the fetal brain already when the baby is developing. So naturally, the baby will go in for insulin resistance and ovulation. The genes will be regulated, folliculogenesis, steroidogenesis, everything gets altered because the LH pulse frequency is becoming more, and that is the reason, there will be more of androgen secreted even from the ovary. Normally ovary secretes 50% of testosterone and adrenal secretes another 50%, but here, it may be altered. And even if you give oral contraceptive pills which are containing anti-androgenic progesterone, you can't suppress the adrenal androgen. You can suppress only the ovarian androgen, because this will be acting on the pituitary and suppress and hypothalamus, and it will suppress the release of the gonadotrophins, and that is how, you can control the generation from the ovary, but the adrenal cannot be controlled. Next. So this is the etiopathogenesis, which I have been going on telling you: genetics, epigenetics, lifestyle. So if we think that in an adolescent she is going to develop most probably PCOS, you can start initiating lifestyle changes. And believe me, it takes a lot and lot of counseling to get them to change their lifestyle. First, the mothers have to be counseled. The mother thinks the child doesn't eat anything at all at home because the child is eating all junk food outside. There is a question of her coming home and eating anything, and the child is becoming very obese. And then there is a problem of image and body image. The child is getting depressed. The child is not doing well scholastically. So all these problems start. Psychological problems also start, and low grade inflammation occurs because of the obesity. We all know obesity is a low grade inflammatory state. And that will again increase the insulin resistance, hyperandrogenism, because all the cytokines which are released will cause insulin resistance in case of inflammation. And clinically, there will be hirsutism, acne, reproductive, like I said, oligoannulation, infertility problems, and metabolically type 2 diabetes and increase in cardiovascular risk factors. Next. So in adolescent, there is a adult life PCOS can be there, and persistent irregular cycles by sixth gynec years, that is 6 years after menarche. And 40% cycles will remain anovulatory, and oligomenorrhea can be there. Of course, oligomenorrhea is defined as 8 cycles in 12 months. It can be less also. Higher testosterone, androstenedione, LH, lower premenstrual serotonin, hydroxyprogesterone, and progesterone, E1 and E2, that is estradiol and estrone, and it can be ovulatory cycle and adult control. Adolescents with anovulatory cycles after menarche more than 3 to 4 years, there can be 57% anovulation, but 43% may still ovulate. I showed you in the phenotypes. And normal LH, 83% will have normal ovulation also. So if the PCOS pattern is more than 2 years, think that they may be a higher risk of PCOS and lifelong abnormality, but don't label them as PCOS in adolescents. Next. So the same thing going on again and again, positive correlation of ovarian volume with LH, testosterone, DHEAS. Again, let me stress that DHEAS is from adrenal and not from the ovary. Androstenedione is from the ovary. Next. So what are the frequency in PCOS symptoms? The menstrual cycle disturbance is 70%. There can be oligomenorrhea in 50%, amenorrhea in 10%. Like I said, there can be even primary amenorrhea. Abnormal heavy bleeding 10 to 15%. Hyperandrogenism, which will be there as acne, hirsutism, alopecia, and acanthosis nigricans. And in fact, most of these children with all these cosmetic problems nowadays are going to the dermatologist, who calls them now as cosmetologists. So they go to them. And obesity 50 to 60%, but there can be normal menstruation in 20%, infertility in 70%, and the abortion rate also will go up. Recurrent pregnancy loss in PCOS, most probably because of the luteal phase deficiency. Early pregnancy loss is very, very high. Next. Like I said, cosmetic concerns, alopecia, acanthosis nigricans in adolescents. Next. So you can look at the acanthosis. Dermatologists feel alopecia is not at all that uncommon. It's around 20%, but we hardly see so much of alopecia. Acanthosis nigricans also, we don't see that frequently in lean people, but obese people, yes, definitely. And please make it a habit to look for this acanthosis nigricans and alopecia, because that will tell us about the insulin resistance, where you can start insulin sensitizers. Next. So, what are all the tests needed? Should we get all these tests done? Not necessary. Like I said, testosterone is very difficult to assess. But if there is a rapid onset of hirsutism and there is clitoromegaly, you must suspect non-classical adrenal hyperplasia. And in these patients, you will have to look for 17 hydroxyprogesterone levels. If it is more than 800, then you have to think of congenital adrenal hyperplasia, and that is where you may have to add dexamethasone. And some of the fertility specialists who add dexamethasone may be trying to suppress the adrenal contribution of androgens, and that is why they add the dexamethasone. And free testosterone, like I said, has absolutely very difficult to measure, and free androgen index also has no role in diagnosis. Next. But you have to test for thyroid, prolactin. Hyperprolactinemia can mimic polycystic ovarian disease. Hypothyroidism again can mimic a polycystic ovarian disease. Once you correct these two, their cycles will become regular and their hirsutism will be arrested. They may not go away, but acne will disappear. And of course, you have them. Cushing syndrome is a very rare condition, as also the non-classical adrenal, congenital adrenal hyperplasia. They are all very rare conditions. Unless there is a very rapid increase of these virilizing symptoms, you should not suspect them. And Cushing's is self-explanatory. You see the Lawrence Moonbiddle syndrome pattern, where there is a moon-like phase, blood pressure will be very high, and they'll be losing potassium in the urine. And so naturally, there'll be hypokalemia, weakness, and all these things. So you can diagnose very easily, and you can refer them to the endocrinologist who is going to take care of them. Of course, normal values for testosterone is 20 to 80. Anything above 80 nanograms per deciliter, that is 8 nanograms per percentage, you'll have to be very careful. And DHEA is 100 to 350, 17 hydroxyprogesterone, which I already mentioned. More than 800 is diagnostic of adult onset of CAH, congenital adrenal hyperplasia. Next. So medical history, again, menstrual frequency, duration, excess facial hair, onset, static or worsening, type of hair removal. This is another big problem which we are facing in the outpatients now, because the mothers, send them to the cosmetologist, or they themselves help them to get this hair removed because of their appearance, because everybody is now very keen on their body image. And severe acne, they can't do anything. They go to the dermatologist, but it is not getting treated. Hair loss, again, location and severity. And voice changes. If there is a voice change, please think of congenital adrenal hyperplasia or a virilizing tumor of the ovary. A very fast increase in the hirsutism, acne, hair loss, and voice change. You have to think of some other condition, not PCOS. Next. So the NIH guidelines offer the strictest criteria for diagnosis of PCOS. They should have hyperandrogenism and chronic oligoanovulation, with the exclusion of other causes, which I already mentioned. Next. This is the Ferriman-Gallwey hirsutism score. Very, very cumbersome. So now even Spiroff mentions that we can say mild, moderate, severe hirsutism, and then you can get away with it instead of going in for 9-site modified Ferriman-Gallwey hirsutism score, like upper lip, chin, chest, abdomen, pelvis, upper arms, thighs, upper back, lower back, all these things. Next. Now, what are the complications? We know it is infertility, primary or secondary, and there can be increase in the pregnancy losses, early pregnancy losses. Obstetric complications, there is 3 times higher risk of preeclampsia, 3 times higher risk of gestational diabetes, 2-fold increase in preterm labor, and 2-fold increase in the growth restrictions. There can be 2-fold increase in the risk of myocardial infarction, 2-fold increase risk of hypertension, metabolic 5 to 10-fold increase the risk of developing type 2 diabetes, increased risk of endometrial cancer, And psychological, fourfold greater odds of depressive symptoms, high prevalence of anxiety disorders. Naturally, there will be decreased quality of life. Next. Now, what about infertility? Next. So, infertility and hirsutism are the two main clinical problems that bring a woman with PCOS to the clinic. Regarding infertility, the main cause is the androgen and LH hypersecretion, which lead to ovulation problems, oligo or anovulation, irregular menses, and reduced fecundability. Irregular periods, oligo or amenorrhea will be the first sign of ovarian dysfunction that can be easily detected in the first visit. Usually, these women will have a very high antral follicle count and AMH concentration. Now, a little caution about the AMH concentrations. Now, originally we used to think AMH can be measured any time in the cycle, but now, of course, we know the follicles recruitment, the recruitment of follicles starts, the antral follicles recruitment starts 3 months ahead of the ovulation. And it is the pre-antral follicles which are secreting the AMH. So you have to measure the AMH in the first 3 days only, like you measure the FSH on the first 5 days, usually it is on the second or the third day, because FSH again is pulsatile. So you'll have to measure that and in fasting state. So AMH is also supposed to be measured around that time, number one. Second thing is AMH should not be taken as such. It has to be correlated with FSH as well as antral follicle count, because not all labs have standardized the AMH concentration measurements, and this becomes very, very difficult. So all three have to be correlated before you say that there is an increased antral follicle count or a decreased ovarian reserve or a premature ovarian failure. Next. So this PCOS is characterized by normal raised LH, normal FSH. It is a low normal FSH and estradiol and normal raised androgens. Estrogens are produced more because of the androstenedione being converted by aromatase as well as leptin into estrone, and estrone can be converted into estradiol. And normal or raised androgens, high AMH, and may be associated with mildly elevated prolactin. Premature ovarian failure or insufficiency, very raised FSH, raised LH, low estradiol, and very low AMH. 2.5 to 4.5 is the normal range of AMH. Hyperprolactinemia characterized by high prolactin greater than 1000 milliunits. If it is more than 200 nanograms per ml, then only you will think of any pituitary tumor, but sometimes even with 100, you can find an empty cella syndrome. With suppressed FSH LH estradiol ratio, weight related and exercise related amenorrhea, that is, they have bulimia or with anxiety, where they have other problems, in such conditions also, there can be very low LH, low FSH, it will become a hypogonadotrophic state. And that again will form a problem. Anorexia nervosa and bulimia. Hypogonadotrophic hypogonadism, it is a structural cause. There can be a failure of hypothalamus, failure of pituitary. So this becomes a very big problem again. And physiological, of course, please don't forget pregnancy in an adolescent woman who comes to you with amenorrhea, because this is very, very important. And a lactation also, there can be a lactation amenorrhea in a woman who has delivered recently. Next. PCOS and pregnancy. Next. So women with PCOS are at higher risk for certain problems or complications during pregnancy. What are those? In addition, infants born to mothers with PCOS are at a higher risk of spending time in the neonatal intensive care unit or dying during or right after birth. Complications of pregnancy arise, such as preeclampsia could be the reason for these, because we may be doing a preterm delivery because the mother is at a higher risk of severe preeclampsia or eclampsia or a HELP syndrome. And then, there can be type 2 diabetes, like I said, gestation diabetes. And also, there can be a early pregnancy loss because of the luteal phase deficiencies. Abnormalities can be more, obesity itself can, and if there are obese PCOS, the complications are much more, because even the malformations will increase in these women. Next. So miscarriage or early loss of pregnancy is very common, 3 times more common, Next. Gestational diabetes, again, very, very common. So these women who have been treated either by ovulation induction, and if you have put them on insulin sensitizer like metformin, biguanide, you may continue it. You may continue it up to 12 weeks, or you may even continue beyond 12 weeks also to prevent the gestational diabetes. That is what is said now. But these women will also require more cesarean sections, and low blood sugar, they have problems, and if they're very obese, they even have obstructive sleep apnea, which again is a risk factor by itself for myocardial infarction. Next. Preeclampsia, like I said, because of the early onset of atherosclerosis, because of the dyslipidemia, they may have preeclampsia, and they may require section, they may go in even for eclampsia. Next. Preterm births, it can be iatrogenic, like I said. C-section delivery, if they are obese with all their complications of obesity with C-sections. And metformin can prevent or reduce the risk of pregnancy problem in PCOS. But remember, metformin is supposed to cause small for gestation age babies or a little less weight in these babies. May not be growth restricted, but they may be small for gestation age babies. And if anybody has PCOS and gets pregnant, you have to work with your healthcare provider to promote a healthy pregnancy and delivery. This has to be, like I said, you have to spend a lot of time with these women counseling. Next. Now, what about the late reproductive age and menopause? As age increases, insulin resistance, abnormal adiposity, everything increases. Metabolic abnormalities also will increase. Weight circumference will increase. It is for metabolic syndrome, we have 5 things, out of which three have to be present to say that they are having metabolic syndrome. One is blood pressure over 130/85, then triglycerides above 150, or under treatment for hypertriglyceridemia, or waist circumference more than 88 in Western women. For us, it is 80 only centimeters. 80 centimeters for us, 88 for the Western women. Or the HDL, high density lipoproteins, which are less than 50, or they are undergoing treatment. And type 2 diabetes, that is where the sugars are impaired glucose, or already they are diabetic and under treatment. These are the women. Out of these 5, if at least 3 are present, we call it metabolic syndrome. Previously, it used to be called as syndrome X. Now we call it metabolic syndrome. So waist circumference, cholesterol, triglyceride levels, all this will increase with PCOS as the woman is aging. And women with PCOS have more prevalence of type 2 diabetes. And next. So the PCOS and menopausal transition, if you look that, more severe phenotypes, like we said, the type A will reduce by the 4th decade of life. That is, the eggs are getting reduced, so the antral follicle count will come down, and so it will not look polycystic. In many patients, the diagnosis of PCOS could no longer be made around menopause, peri or post-menopause, and the phenotype was less severe during this age period. However, we don't know whether the improvement in PCOS phenotype is during peri or post-menopause is associated with reduction in the long-term complications, like we said, hypertension, atherosclerosis, metabolic syndrome, or type 2 diabetes. All this we are not very sure still. Next. So this I have already talked about. Next. So how do we screen? We have to screen, look at their body mass index, lack of physical activity, smoking will add to the risk. And if there is a family history of type 2 diabetes, all the more a problem. Dyslipidemia, hypertension, and type 2 diabetes, and of course impaired GTT. Next. So the outcomes across the life course, adolescence, insulin resistance, obesity, hyperandrogenism, oligonucleation, reproductive age group, infertility, hyperandrogenism, obesity, all those things, and post-menopause, cardiovascular, obstructive sleep apnea, endometrial cancer, depression and anxiety, normal. Next. So these are all the risk factors. Again, in a tabulated form, there will be premature atherosclerosis. And let me also add a word about non-alcoholic fatty liver disease, that is the steatosis. We call it steatosis or steatohepatitis, and this can also lead to liver failure. we have to counsel them. And these women with who have these polycystic ovaries, PCOS hormonal changes will be insulin resistance, hyperandrogenism. But traditional risk factors, central obesity, dyslipidemia, hypertension, impaired glucose tolerance, all this will cause an oxidative stress. Obesity itself causes chronic inflammation, sympathetic nervous system dysfunction, hyperandrogenism, vitamin D deficiency, and there can be a problem with hemostasis because the fibrinolysis imbalances, their mood disorders, and gut microbiota also is supposed to alter because of dysbiosis, and epigenetic alterations are there because of which premature atherosclerosis can happen because of the endothelial dysfunction. Intima media thickens, coronary artery calcification occurs, and believe me, women postmenopausally have a higher incidence of myocardial problems or myocardial infarction, and their mortality rate is much higher than in men. And they reach the hospital also late. Next. So the same thing again, postulated mechanisms, menopause, eating, and estrogen and the sex hormone binding globulin will come down, androgens will go up naturally, and the PCOS, again we know the problems, and visceral adiposity persists, and there will be a metabolic syndrome, endothelial dysfunction, atherosclerosis, and cardiovascular disease. Next. Now, obstructive sleep apnea. This can be usually because of the obesity, we think, but there can be some other mechanism also being involved, like insulin resistance, the adipocyte problem, hyperandrogenism, and the sleep fragmentation. Because the sleep is not there, they fall asleep in the afternoon because they are not able to sleep in the nights, but they're getting up very frequently. And there is sympathetic activation, and because of this, there is oxidative stress, systemic inflammation, hypothalamic pituitary adrenal axis alterations, adipokine alterations, intermittent hypoxia, and they are more likely to have cardiac problems and myocardial infarction. They may simply die in the sleep also if they have obstructive sleep apnea, and they need to see a sleep specialist. This has become a very big specialty now, sleep specialist. So that is very, very important. So the one thing which you should ask our women when they are obese is, do they snore? They will not know whether they are snoring or not, but the partners will know whether they are snoring or not. So you have to ask this question. And if it is there, they have to be referred to a pulmonologist who are also sleep specialists, or the ENT specialist, or to the sleep specialist if they are available. Next. So this is the health implications which we have mentioned a number of times. Next. So 14 to 21 and advanced age, you have to look at all this. There is a change. So over the years of 40 years, their cycles become regular, and because these people have more estrogen being produced, the antral follicle count is still there. It has not disappeared. It has not become less than 1,000, which occurs usually in the normal women. So they will have less vasomotor symptoms, but they are obese. And if they are obese, they will have less vasomotor symptoms because the adipose tissue itself is converting the androgens into estrone. So because estrone is there, there will be fewer vasomotor symptoms. And of course, because of obesity, there will be insulin resistance and metabolic syndrome, which are all going to be there in adolescent and reproductive age group women. Next. So again, the same thing. The history has to be taken in women who develop endometrial carcinoma, because we know the risk factors like hypertension, obesity, infrequent periods, history of PCOS, all are the indicators for developing endometrial cancer. And nowadays we are seeing younger women having endometrial hyperplasia, especially in PCOS women who are coming to us for infertility treatment. And these are the women, who are going to have a big problem, because you do a endometrial curettage because their endometrial thickness is beyond 12 millimeters in reproductive age group, and you get a well differentiated adenocarcinoma of the endometrium. In such conditions, what will you do? They want a child. So there are only two options. Either you give them, with all the risks associated, an intrauterine progestation system for a restricted period, then take it off and ask them to go for an IVF ET, or if they are opting for surgery, then You can send them for egg freezing and then surrogacy so that they can deliver. Next. Now, oral contraceptive use and its consequences after menopause. Oral contraceptives are usually recommended as the first line treatment in adolescents. We all know that for the menstrual abnormalities. So, there is no risk of weight gain with OCS. There are a number of papers now about that. Mood changes also may not be there. And in fact, estrogen is supposed to raise the blood pressure, but progesterone counteracts that. But then again, progesterone will increase the insulin resistance, whereas the insulin sensitivity is increased by the estrogen. So there is a balance. So we need not worry so much about oral contraceptive pills being prescribed in the adolescent age group, which may cause problems later in menopausal, perimenopausal, postmenopausal women. Next. So again, there is an advantage. The beneficial effects of OCC is reduction in endometrial cancer as well as ovarian cancer, which persists even 10 years after the stoppage of cessation of oral contraceptive use. Next. Now, how do we manage all these women? Next. So the current recommendation, like I said, in adolescents, you don't make a diagnosis that fast, but you examine them, give them counseling about the lifestyle changes, and ultrasound data, please consider carefully. And you tell your sonologist not to mention that it is polycystic ovary. Instead, they should say it is a multicystic ovary. Instead of saying polycystic ovary, if they say multicystic ovary, that is more reliable in adolescent age group. Next. Treatment goals in adolescent PCOS is obesity, the cosmetic problem, and then the irregular menstrual cycles or amenorrhea. Now, acne, hirsutism, irregular menstrual cycles, all can be treated with our oral contraceptive pills, which has a low dose of estrogen, ethylene estradiol, less than 20 micrograms, but add a progestogen, which is an anti-androgen, like you can add drospirenone or cyproterone acetate. The only problem with cyproterone acetate is that it can cause a little weight gain, but it is very good for acne and hirsutism. Though drospirenone is also good for that. And for obesity, lifestyle changes are very, very important. So these are the goals for adolescent PCOS, and this is what we have to tell. Now, when you are prescribing oral contraceptive pills for an adolescent girl, the mother is worried. The mother thinks of only side effects of oral contraceptive pills. Like I said, you have to counsel the mother also about the oral contraceptive pills, the beneficial effects of the oral contraceptive pills. And as a matter of fact, what is said is if the child has hirsutism and wants to go for cosmetic management, at least for 6 months, you put them on a oral contraceptive pill with as an anti-androgen progesterone so that the hirsutism stabilizes. Then they go for her electrolysis, laser, and other treatments, so that there won't be fresh growth of hair, terminal hair for these children. Next. Now, like I said, lifestyle modification for obesity, and also we must tell them to avoid alcohol, smoking, psychosocial factors. It is more for Western women, but our women are also catching up because you see, special ladies' day in pubs and special most of these software professionals. I have seen, almost 25% increase in smoking. So that becomes a big problem again. Next. Now, like I said, oral contraceptives, the advantages, it reduces the endometrial hyperplasia, so the cancer risk is reduced. It acts on the pituitary, so naturally the FSH, LH, both are affected, both will come down. So ovarian androgen comes down. And because of the estrogen, the sex hormone binding globulin goes up. So it binds the testosterone, so free testosterone comes down. So naturally hirsutism and acne will improve. Now, long-term benefit on reproduction, once you stop the oral contraceptive pills, the whole problem is going to recover. So can you give only cyclical progesterones because the child is obese and is also using these oral contraceptive pills? The one risk we have to think of is the venous thromboembolism, especially if the child is having a sedentary lifestyle, going to a coaching class and sitting there from morning to evening. It's going to be a big problem. So you'll have to counsel them about all these things. and you will have to give a very low dose of ethylene estradiol in these women. And of course, in the reproductive age group, infertility, ovulation, induction. Next. Of course, cosmetic, they have to go to the cosmetologist. Another drug which can be added is spironolactone. It is also like drospirenone only. You give 50 to 100 milligrams twice a day, but this is usually associated with the irregular cycles. So you usually add it along with oral contraceptive pills. Like I said, cyproterone acetate is also progestogenic. It is very good in acne, especially, and flutamide. There is a finasteride, which is an anti-androgen, and flutamide, which is also anti-androgen. Finasteride we don't use so much, but flutamide, 5 milligrams can be added because finasteride has a problem with the hepatic toxicity. Next, and usually, should we add metformin, insulin sensitizer, or not? One of my endocrinologist friends told me that gynecologists use metformin like Ganga Jal. We use a lot of metformin, they think. But you need not use metformin for everybody. But some of the endocrinologists also use metformin very frequently in PCOS cases. But once you know that, you do, there are lots of tests to know about the insulin resistance. But the easiest will be, the hyperinsulinic euglycemic clamp is the best, I believe. The HOMA is there. You can't be doing all these things very cumbersome to know the insulin resistance. Like I said, presence of acanthosis nigricans tells you that there is insulin resistance. Then you start off metformin. Always start with a low dose and then slowly increase it, because there are lots of side effects with metformin. And please don't think that metformin is going to reduce the weight. Many people think, if you give metformin, the weight reduction will occur. It is not because of metformin, but because it reduces the appetite. They may lose weight, and it also prevents glucose absorption from the gut, and it increases the glycogen formation. That means gluconeogenesis is prevented, and naturally it will improve the serine phosphorylation. It acts in the first messenger. Insulin acts at the cell membrane. There are two substrates, insulin receptor substrate 1 and 2, like I told you, where tyrosine kinase action is very important. That is where the metformin acts. So if there is insulin resistance, there is a lot of serine phosphorylation. This prevents it and improves the tyrosine kinase and the phosphorylation, so that the receptor complex will act, and the second messenger has to be acted upon by some other drug, and usually the inositols are supposed to act on the second messenger, at the second messenger level. We will come to it at a later stage. Next. So metformin is supposed to increase the cyclicity of menses also by reducing the insulin resistance, but we are not very sure. But should we just give metformin for as an induction of ovulation where they will conceive? But it is controversial. But if there is clomiphene resistance, that is, you are giving clomiphene for induction of ovulation, after 6 cycles also there is no ovulation, then you may add metformin, and then there can be a improvement and there can be ovulation. So that is one thing which we can do. Next. Now what about inositols? Inositols are sugars, and usually they are present. There are a number of inositols, but the most important of them are myoinositol and d-keroinositol. Now when you look at PCOS and normal women, inositols are low in PCOS women. Next. So what are the functions of inositol? This is a second messenger. So it aids in the intracellular calcium ion transfer. It maintains the cellular membrane potential, because the inositol phosphoglycans, which form at the level of this, they will act, and they will act as a second messenger. And then, they will make the insulin receptor substrate to alter the RNA and DNA, so that the effect will start, insulin effect will start. So the metabolic effects are insulin signal transduction, lipolysis, serum cholesterol decreasing, and others are serotonin activity modulation, nervous system regulation, and gene expression also improves. Next. So this is what I already mentioned, The insulin receptor resides in the cell membrane, but the subunit is phosphorylated by insulin. Insulin receptor substrates are activated. P13K docks on the to the insulin receptor substrate, which then leads to phosphorylation. I spoke to you about that of phosphatidylinositol and eventuating the insulin action. Myoinositol increases insulin sensitivity by making more phosphatidylinositol available. Now let us also talk about inositol action on the ovary. The paradox in ovary is the ovary has no insulin resistance. Everywhere there is insulin resistance, but there is no insulin resistance in the ovary. And myoinositol and d-chiroinositol both are important in ovarian action because myoinositol improves the uh, FSH receptors on the granulosa cells so that the egg quality improves. Whereas myoinositol gets converted into d-chiroinositol in the ovary by the action of an enzyme known as epimerase. And D-chiroinositol is acting on the theca cells by producing androstenedione, and this androstenedione is getting converted to estrogen, which improves the FSH receptors again. So there has to be a balance between myoinositol and D-chiroinositol. In a PCOS condition, it seems that the epimerase action is increased in ovary, what is known as the DCI paradox or D-chiroinositol paradox. So what happens is the myoinositol is getting converted into more of D-chiroinositol, and D-chiroinositol is producing more and more of androgens. And so naturally the egg quality comes down, and because of the decreased myoinositol, the FSH receptors are not being increased in number. So their quality goes down. That may be one of the reasons, why in PCOS their quality may not be good. So if you are adding insulin from outside in 40:1 ratio, then it is supposed to help in the ovarian metabolism also and improve the insulin action. Now, another problem with the insulin acting on the ovary is it also has a similar action. Its receptor and insulin like growth factor 1 receptor are same. So insulin resistance can occur because it goes and docks into insulin like growth factor 1 receptor and it prevents its action. So that again can cause a problem. So that is what is the inositol problem there. And adding myoinositol and d-chiroinositol in the proper manner and ratio is supposed to improve this action of second messenger. The only problem with myoinositol and d-chiroinositol usage is it's a little expensive compared to metformin. Next. So inositol with the phospholipid calcium as secondary messenger, the oocyte revolution, maturity and fertilization occurs. Next. Next. Next slide, please. So this is the MCI DCI in PCOS. Insulin resistance diminishes. Weight loss also occurs. Insulin levels become normal. LH levels naturally will come down because the androgens are going down and menses become normal. And inflammation of ovarian theca cells comes down. Androgen levels will come down and fertility is also reduced. And it normalizes the insulin signaling and glucose metabolism. Next. It is also supposed to improve the GLUT4 transport of glucose also, so that it increases the uptake of glucose by the skeletal muscle and as well as the adipose tissue also. So in the treatment affected by teenagers affected by PCOS, a clinical study says that it does improve the obesity as well as if there is a weight reduction, there is a decrease in the insulin resistance. Next. So administration of MI is safe and effective to prevent and correct metabolic disorders in teenagers. Combining MI with OC pills, anti-androgenic effects are enhanced and negative impact of OC pills is improved. If myoinositol is given more than 12 grams, only the side effects start, like nausea, gastrointestinal side effects, and dizziness. But otherwise, the amount which we are administering, it will not cause any side effects. 4 grams is the one which is being given in divided doses, and it is safe. Next. So 4 pillars of PCOD management with MIDCI is 4 grams per day is optimal MI, and the optimal ratio is 40:1. Tablets, capsules have lower absorption and can alter efficacy. Taste and acceptability by patients impact efficacy. So the powder, which is mixed in water, they can take. Now they say the soft gelatin capsules, which can be made, the absorption may be a little increased. That is what is said now, the recent reports. Next. So the infertility, again, you have to try the ovulation induction. In PCOS, the one problem with the ovulation induction is OHSS is very important. It increases in PCOS women, and letrozole will be much better because letrozole causes less OHSS, ovarian hyperstimulation syndrome, and it releases single egg, so singleton pregnancies are more common. So that is the first preference in PCOS women. Clomiphene citrate may not act. There can be a clomiphene resistance in these women. There may not be an ovulation occurring with clomiphene citrate alone. Metformin is added into this, and gonadotropins is the last resort because it can cause more incidence of OHSS. And of course, if you have used letrozole, if you have used clomiphene and with metformin, nothing has happened, maybe you will go for either laparoscopic drilling, where you have to be very careful, not more than 4 punctures, not more than 1 or 2 millimeters. And gonadotropins is the other alternative. Next. Now, like I said, letrozole, the evidence which is based on international consensus is in 2018, where letrozole is not available, you use clomiphene. Otherwise, it's better to use letrozole as the first treatment, first line treatment for induction of ovulation. Next. So how to use you give 2.5, slowly increase it to 5 milligrams. You can continue to do it till there is a follicular maturation, and then you can once the ovulation occurs, you may give a trigger, or you may just allow her to naturally ovulate and advise her to have sex at that time, because it is always ovulation induction and timed intercourse. Next. So you are doing a follicular study also. This is an extended letrozole protocol. You are doing a follicular study and measuring the follicle measurement, and till that time, you continue with your letrozole. Next. This is the step-up protocol. Then clomiphene citrate, again the same thing. You can go for a step-up protocol. Use 50 milligrams and slowly increase the dosage if it doesn't start. But 6 cycles of clomiphene citrate, and if there is no ovulation, it's a clomiphene resistance. And then you will have to go for the addition of metformin or switch back to letrozole. Next. Same thing, no ovulation, you increase to 100 milligrams, then 150. You go on doing that. Next. So what does the evidence say? Same thing again, should be used in women with PCOS with anovulity infertility, no other infertility factors. Of course, in PCOS women, you have to test for every other factor also. So you look for thyroid, you look for prolactin, you look for tubal factor, and the anatomical factors. All this must be normal, and the male factor most important. So once you know that, then you can do all these things. Next. What about concerns about metformin? They have adverse effects, which I told you, and it appears safe, though in pregnancy, even if they conceive, it can be, there is a placental transfer of metformin, but there is no evidence of any malformations in the babies so far. But the only thing is with metformin, because of the gastrointestinal side effects, the B12 and folic acid has to be added, B6. All three have to be added into this. Next. So inositol favors clinical pregnancy versus metformin. So either you add metformin or you add inositol, myo-inositol 4 grams versus insulin sensitizing agent metformin. Even myo-inositol is also a insulin sensitizing agent only, but it seems to work better with less side effects. This is Cochrane library. Next. So again, inositol favors the cumulative live birth rate in patients who have been induced with ovulation. That is again from Cochrane library. Next. Again, still favors clinical pregnancy as IVF pre-treatment. Even in IVF, the pre-treatment. I'm not a fertility specialist, so I'm not going into the details of all this. Next. So antenatal dietary supplementation with myoinositol in women during pregnancy for preventing gestational diabetes. Does it prevent? We don't know, but they say there can be an effect of myoinositol which prevents gestational diabetes. Next. Now, gonadotrophins, I won't talk much about gonadotrophins, but in women with PCOS, the antagonist protocol is supposed to be much better, and HCG should be withheld. Like I said, OHS is very, very common, and if there is a severe OHSS, we may even lose the patient. So it's better that we use the other drugs rather than gonadotrophins, and it is always better that the ART specialists use these drugs and not the general gynecologist. Next, same thing again. Next. Now, laparoscopic ovarian surgery, I already alluded to, not more than 4 punctures, not more than 1 to 2 millimeters. Don't use too much of, don't think that laparoscopic ovarian drilling is going to be much safer than your vaginal section. That also can cause 30% adhesions between the tube and the ovary. Next. Now, what is the peculiarities of IVF and PCOS women when the first line fails? Goal is pregnancy and the priority is safety. That means you don't want any OHSS and you don't want the multifetal pregnancy. Twins is okay, but if it is more than that, it's going to be a problem again because you have to go for fetal reduction and all those things. Next. So, cumulative live birth rates after IVF in patients with polycystic ovary, the phenotype matters. The severe the phenotype, the less the number of pregnancies. So hyperandrogenic PCOS phenotypes confer significantly lower cumulative live birth rates compared with their normoandrogenic counterparts. So the phenotype also matters there. Next. The same thing again, the cumulative live birth rates after IVF in patients with polycystic ovaries, like I said, the phenotype matters. If you look at the A, C, D, and the first type, here, the cumulative live birth rates is COCs, freeze all, and usually they do, frozen embryo transfer in these women. The more severe the PCOS phenotype, the lower the probability of cumulative live birth rates. Next. So the metabolic syndrome on female fertility and in vitro fertilization, if they are type 2 diabetes, already they are having a metabolic syndrome, then women with PCOS with metabolic syndrome have a negative impact from female fecundity, and this suggests an adverse effect on in vitro fertilization cycle stimulation characteristics and clinical outcomes. That means lifestyle changes are very important. If they are type 2 diabetic, then their sugars have to be very, very normal and they have to be controlled. And if they are already hypertensive, their hypertension also should be controlled. And then only they can be sent for this. And these women are going to have lots of complications during pregnancy also. Next. Again, I won't go into these recommendations. Like I said, antagonistic cycle is very important. And where you are looking for ovulation with gonadotrophins, the number of follicles are more. And if the estradiol level is very high, you just skip the HCG. In spite of which they may conceive, there can be ovulation, there can be a multi-fetal gestation. So these are things which can occur with gonadotrophin. So you have to be very, very important, very, very careful in these women. Next. So the choice of FSH, it can be urinary or it can be recombinant. It doesn't matter. But it is always better, recombinant LH should not be routinely used in combination with FSH because already they have high LH. So that becomes a big problem for them. Next. So should we add metformin? There are controversies about this. Again, in IVF patients, fertility treatments, metformin is supposed to improve the incidence of pregnancies and cumulative live birth rates, but we are not very sure about it. Next. Again, the same stimulation. Next. Now, individualization of controlled ovarian stimulation in IVF using ovarian rhizome markers. So from theory to practice, you have to go for Ovarian reserve, if it is high, you expect a higher response. So you use an antagonist. That means OHS is very common, where the antral follicle count is very high. If it is low, you expect a poor response. And if it is a normal ovarian reserve, then the standard treatment can be followed. But where there is a high number of antral follicle count, you will have to use very minimal FX stimulation, and antagonist protocol is the best. So you have to look for the antral follicle count. Next, and the AMH. Now, like I said, the frozen embryo transfer is supposed to be better in these women. Next. Now, in elderly women, we are not very sure whether PCOS is the cause of all their metabolic problems, or it is already there in their genes. So, once a diagnosis of PCOS is confirmed, a cardiometabolic risk assessment, including estimation of blood pressure, BMI, lipid profile, oral glucose tolerance test, is recommended. So, it becomes part of the menopause protocol, menopause management protocol. Patients with normal glucose tolerance should be rescreened at least every 2 years. I would say 6 months, in fact, and more frequently if additional risk factors are detected. So if you look at the metabolic syndrome factors, and if 3 are positive out of 5, it is better that every 6 months we start testing them, or earlier also. In the event of impaired glucose tolerance, an assessment of type 2 diabetes should be performed, and they should be informed about the signs and side effects of sleep apnea, which I told is a very big cardiac risk. And again, the cardiovascular disease must be prevented, and they also should be counseled about the endometrial hyperplasia and carcinoma. We all know there are no screening procedures for endometrial cancer, unlike the cervical cancer. So we have to be very careful. And lifestyle, the sheet anchor of management of PCOS is lifestyle management. Next. Thank you very much. If there are any queries, I can take them up now. Thank you.
Thank you, ma'am. Thank you for your excellent and superlative talk. It is always an honor to and learning to hear you, ma'am. Ma'am, if you allow me, then I will read out the questions for you from the
Yeah,
participants.
sure.
So we have a first question. What is the role of isoflavonoids in the treatment of women with PCOS?
Isoflavones has no role at all. I'm being very categorical. There is absolutely no role. Because you see, you require an equal in the intestines for the isoflavones to act. They have to be converted with equals to the active form, And what is it going to do? They are only estrogen. Already in PCOS, there is high estrogen level. So why do you need estrogens in these women? Logically, we'll have to think.
Thank you, ma'am. We have one more question. Does vitamin D deficiency increase the risk of metabolic syndrome in women with PCOS?
Yes, I think vitamin D has become the end all and be all of management in every condition now. Like what used to be vitamin E some years ago, we don't know. But vitamin D deficiency is definitely is going to is supposed to be problem with to induce metabolic syndrome. So you will have to test the level of vitamin D, and if it is deficient, yes, definitely give it. If it is not deficient, and if they have sufficient amount of vitamin D, please don't supplement, because there can be hypervitaminosis.
Thank you, ma'am. And ma'am, I don't find any additional questions in the comment box.
Oh,
So if you allow me, then we will close this webinar.
thank you. Thank you so much, Sumesh. Thanks a lot for all the slides. You
Yeah,
just got them done as to what I required. Thank you.
yeah. Thank you, ma'am. It was, it was our privilege to have you here. Yeah.
Thank
Thank
you.
you, ma'am.
Thank
Yeah.
you.
Many thanks from the Shield team for all the delegates. Yeah. Thank you, ma'am.
Thank you.